my name is Lena Halonova. I am Secretary General of this society, and I would like to introduce another speaker which accepted our invitation to give a speech during this ISPRS webinars organized due to the health restrictions and situations which brought us from the in-person life to the virtual one. So Petra Helmholtz is a senior lecturer in photogrammetry within spatial sciences at Curtin University in Australia. Her work includes teaching and research, and her current research interests focus on application and the driving research using photogrammetry in the areas of health, agriculture, heritage mapping, and engineering, as well as underwater photogrammetry. She is the National Chair of SSI, Remote Sensing and Photogrammetry Commission, and the course coordinator of the Bachelor of Surveying degree at Curtin University. So this is a brief introduction, and I would like to ask Petra to start her speech. So Petra, please.
Thanks a lot, Elena, for this lovely introduction, and thanks for the opportunity to talk today. Today I try to do something slightly different. Bit of a first thing for me is I will try to use Slido during my presentation. I'm pretty sure, or I hope that you have heard about Slido already. Slido is a web page where you can go to. So on the top left hand of my first slide, you can see the address and the pin. And what Slido gives me the opportunity is to basically interact with you, to ask what's maybe your background experiences are in allied health. Before I start with the first Slido slide, I would like to acknowledge the contribution of many other people who are part of the projects as well. So let's get started and let's try if the Slido works well. So if you now go to the Slido web page and using the pin, you should be able to respond to the question which is in front of you. So my question to you guys at the moment is, have you worked in projects, interdisciplinary projects outside of science and engineering? So who is brave enough to do the first click, guys? So if you don't mind. Yes, we have the first person. Let's see how many of you have. Wait a bit longer, but it looks like there's a clear trend that the majority of you have only cooperated within science and engineering. Keep clicking. I quickly will explain in the meantime what I understand under allied health. So at the moment now, one of you has said yes in medical research and allied health. What allied health is are professionals who base who use evidence-based practice to prevent, diagnose, and treat various conditions and illnesses. Okay, so that means there are clinicians who work in areas such as speech pathology, genetic counselors, speech pathology, and so on. And it looks like some people changed their opinion that only within science and engineering interdisciplinary projects were undertaken by the audience, which is excellent, because then I can tell you a little bit more about my journey actually to work together with people outside of the field of science and engineering. And it's a quite different world, let's say it this way. So let's move on to the next slide. So what I try to do today is I try to introduce this journey of interdisciplinary research in science and allied health. And I will highlight, as the title of the presentation says, 2 projects. What is very important if you work in the field of allied health is to get a very good understanding of the issue the clinician has which should be solved. So all of the clinicians that have worked in the field for many years, there's lots of body of knowledge and research in their field available as well. But with introduction of new technologies and opportunities like 3D cameras or AI, actually they start to identify issues and gaps in their research, which we now are able to fill. things which could not be filled in the past, but now with the new technology and methods available, it can be solved. So I circled this in red because that's of course the first step. That's a step which takes quite a bit of time to get your head around what's going on. How can we help? Can we actually help? And then to formulate the problem. I want to highlight that scientists and photogrammetrists and computer science as well, they are just one of the stakeholders on the journey. Okay, so often people have the idea, well, I can solve X, Y, Z. Well, maybe you can't because you haven't really understood the full complexity of the issue. So scientists and clinicians have to work very closely together in order to find a solution to the existing problem. But then in order to actually implement it in a clinical workflow, that's just the start. So it's just here. Then the first step is, well, you have to find a small local group, a user group, which you can use to test, to verify, to do your first steps of to check if you actually can do impact with the research you try to do. And you can see by the arrows, it's always a backwards and forwards. So maybe they identify one issue, it goes back, and then it at one stage, hopefully it goes to the next level up. The next level up is then to develop the tool and to try to find out if the tool, the thing you have done so far, actually can make a difference for the patient, can make a difference in the clinical environment. And then only if this is verified, if you can show that, yes, what you have developed can make a difference, so then you can go to the implementation stage. And when it's implemented, of course, you have to monitor, you have to evaluate, and this is longitudinal. It will take many, many years. And then you can fill the circle and go for the next iteration. When we start to work with allied health, one of the things what I normally hear is the main issue is ethics. Ethics is just the first step. Ethics is very important. We have to understand the requirement of the national health providers and of the medical research councils, but it's just the first step in order to get started. What I learned is that the next big challenge is actually communication, because those people speak a different language to us, science and engineering. So for them, curvature means something else than what it means for us. We really have to understand. We have to find a toolkit of words where you agree on, where you have a better understanding what the other person means. All right, so I will try to take you on this journey. I picked two projects. One is a project called Cliniface, and the other project is called Smart. Cliniface is connected to genetic counselors and to rare diseases, and Smart is in the area of speech pathology. All right, let's get started with Cliniface and rare diseases. On the picture, you can see Optus Stadium in Perth. It's a beautiful venue with 60,000 people. Whenever you can travel again, maybe it's worth to come to Perth. And if you come to Perth, maybe come during the Australian football time. So why do I show the image? So I said that 60,000 people fit in the stadium, and 60,000 people is the number of children just in Western Australia itself living with rare diseases. Okay, that so rare disease is defined, or disease is defined to be rare when it affects fewer than 1 in 2,000 people. However, there are over 7,000 known rare diseases. So while one disease is rare, not very common altogether, lots of people are actually affected by rare diseases. In Australia, it's 1.5 million approximately. In the US, between 25 and 30 million. And in Europe, around 30 million people live with rare disease. Just some more background is that 30% of the patients are referred to 6 or more specialists. That's a long journey for the people to find out what's actually wrong. If it's a long journey, and sometimes it can take up to 30 years, that means the treatment cannot be customized. So the living of the person is impacted a lot. And half of the initial diagnosis is actually wrong. And Yes, so that's where the patient of the clinicians come from in order to support people with rare diseases. So where do we fit in the field? There's one interesting fact, and the fact is that 1/3 of the rare diseases has very subtle facial clues. So it means deformations in the face. If it's deformations, that's something we can measure. That's where computer science and photogrammetry and surveyors can help. All right, for example, talking about subtle clues in the face deformation, I would like to introduce the term of facial phenotype. So a phenotype is the composition of the person's observable characteristics, basically the way we look like. Okay. There are two factors which contribute to the way we look like. It's first our genetic code. Yes, we look similar to our parents. There's a good reason for that, but also environmental factors. And as mentioned, providing the facial clues provide a clue for identifying rare diseases. I want to emphasize it's just one tool in the toolkit. Of course, there are lots of genetic testing and other things as well, but it's just one tool in the toolkit, which has been used by clinicians for a long, long time. So it's not novel, but now we can, it's not novel, but the clinicians have identified a gap, as mentioned beforehand, where new technology can help to fill the gap. So first of all, in order to train a person to read the phenotypical traits, needs lots of expertise and experiences. Right, so you have to train people for a long time in order to recognize all of the subtle characteristics. Then there's a challenge that some of the phenotypes are also overlapping between different diseases. Then different ages can have different onsets. So the face can look for one rare disease in one age group completely different to another age group. Then, of course, we have lots of different ethnic groups, and they have different normal variations as well. So overall, the clinicians have identified there's a gap in objectivity. So if they can measure some of the facial characteristics more objective, more reliable, more precise, then there's a better chance to actually find a diagnosis of a rare disease using these facial clues. In order to overcome the lack of objectivity of the criteria, something called the human phenotype ontology has been introduced, which is a structured set of well-defined terms. And these terms define what's abnormal, and then the abnormal, what is abnormal can be related to rare diseases. So, as mentioned, clinicians always used to measure elements in the face. There are lots of historical data around. This has been done for many, many, many years. But they're normally used manual measurements, used, for example, measuring tapes or calipers and other devices. So if you want to measure distances between the eyes in a child, while it's not very safe to use a pair of calipers because you have a metal object very close to the eyes of the person. If you use measuring tapes, well, if you do it by yourself, if you try to repeat one measurement, the precision is very bad. But not just the precision, sometimes also the accuracy, meaning you have a bias in your observations. So while it's done a lot, there are lots of issues with to create precise and accurate measurements. That has been replaced for quite a while as well using 2D images. So 2D images, the big advantage is we can repeat the measurements. So the patient doesn't have to come back if you want to do a new measurement. But we all with a background in photogrammetry now, while if you have 2D faces or 2D images, while we have perspective distortions, we have limits in the types of measurements we can perform. We generally don't have scale and so on, and lighting, different lighting and pose issues can contribute as well to imprecise measurements. So what we can use while 3D scans, 3D cameras, we can take 3D images of faces, and that's actually 3D, everything in 3D, and I will show a video and maybe a live demonstration later on, where we can create very complete and precise representation of the whole face, of the whole shape of the face. We can perform very accurate and precise measurements, but the challenge is it's not fully adapted in clinical practice, and often there are also knowledge gaps in order to do that. All right, just to give an example how those measurements are used for finding a HPO term. So I mentioned HPO term is an abnormality in the face. So I picked one of the HPO terms, and there are many of them, as mentioned, over 1,000, which is hypertelorism, which means that's the increased distance between the eyes. So just a couple of examples shown here. And the HPO, the human phenotype ontology, has a very precise definition what it means to have hypertelorism. Okay, that's the interpupillarity distance, the distance between the center of the two eyes. Should be above 2 standard deviations, and normally there are norm curves around defines what is normal and what is abnormal. So that's the face of the computer scientist who implemented the software, Richard Palmer, and because of ethics reasons, I use his face or faces of our team. Well, if you use 3D faces and we use 3D measurements, so for example, you can detect landmarks, and algorithms are available to detect landmarks in 3D faces. But if you have the landmarks, then of course we can derive metrics, in this case the distance between the eyes, and if we have the metrics we can then compare to the normal data. We can use the interpupillary distance, or we can use the inner and outer corner. So we can use the cancel distance, which is the distance between those two landmarks. It's the outer cancel or the inner cancel. So we can derive measurements, and then we can correlate the measurements with normal data, and we can find if something is abnormal in the face or not. If something is abnormal in the face, it doesn't mean that you have a rare disease, just straight out. It does not mean that. If something is abnormal, it's just a hint that there is maybe something wrong, but it has to, of course, comes normally with other conditions as well. So just because you're concerned that your eyes are too far apart doesn't mean that you have a rare disease. But it's a tool for clinicians. So how can photogrammetry help? So what's a technical workflow in order to provide more objective measurements to the clinicians? First of all, we capture 3D images, and in order to keep it simple, to be able to implement it in the clinical workflow, we use existing camera systems. That's, for example, the 3DM system. You can see here a number of different cameras. There's another set of cameras on the other side. It uses structured light. The person faces into the cameras, and then with a snapshot, the images are taken. Stereo photogrammetry is applied, and we can create a 3D representation of the face. That's another camera down here. That's a vector camera, where there's a special lens system which basically creates a stereo camera, and then based on the stereo camera information, again, we can derive 3D measurements. That's one of our other team member, Yareli Thomas, and you can see that lots of our research is also connected to Aboriginal Australians. And I will come back to this a while later on. Well, then, if we have our 3D face, we have to try to find our landmarks. And we can click this, but of course, being background in photogrammetry and computer science, we try to provide initial readings to the clinician. So we have a 3D mask where we have exactly the position of the landmarks, how it's defined in the terms of clinicians. So they're not just random landmarks, they're specific landmarks allocated to different muscles in the face and different areas in the face. So we cannot just use any algorithm. We really have to make sure that we use the right location of the landmarks. Then we have the target surface area. In this case, it's my face. And again, because of ethics, I could not show you a patient face in this case. And we want to transfer those landmarks from the mask onto the target surface area. And we can do this using viscoelastic affine transformation. And if you're more interested of how this is done, then I would refer to one of our papers. But then after the step, we have basically our landmarks. If we have our landmarks, then we can try to derive our measurements. And then the measurements can be compared to normal data. So what we did, we tried to validate our measurements. So we had 10 inter-landmark landmark distances. So distances of the most common use features in the face. And we had overall 25 adults, which of which we captured 3D data, 2 different cameras, and we tried to compare of what expert clinician can derive compared to what our system can derive, how much the measurements we can get out of CliniFace. So that's, I would like to briefly explain the first figure. On the first figure, the reference of all of the 10 measurements is done by experts and use a caliper. So that's the best practice, the highest best practice standard, which is at the moment used for clinicians. And then we compared those measurements with the expert using a measuring tape, non-experts using CliniFace, or CliniFace placing the landmarks automatically. What you can see, which is interesting, is that the bias of this clinician of using him using a caliper and the measuring tape. So the clinician, even it's the same clinician, the same expert, the same experience, using different tools, he introduces 3 mm bias in his measurements, which is really concerning, because if I want to use the normal data in order, or comparison to the normal data, 3 mm can be a huge difference and can put someone on the list of normal features compared to normal features. If you use CliniFace and non-expert, just using instruction and how to use CliniFace and how to place the landmarks, we can see that the non-experts using CliniFace are actually very close to the mean, to the reference. And CliniFace, just using the automatic placement, is very precise and very accurate as well. All right, and then next step was that we wanted to compare the measurements non-experts can do compared to the measurements of expert using CliniFace. So here's a reference which are used. So the 0 is the expert using CliniFace. And you can see that the automatic system CliniFace as well as the expert, non-experts getting very close to the truth. There's a bit of a high variance, and there was only one non-expert which had the bias of around 1 mm. And if I remember correctly, it was me, because I did not read the instructions correctly of where to place the landmarks. So overall, what we showed, so coming back to the circle, is that CliniFace can overcome one of the issues clinicians have, and that's to provide more objective measurements. Just to try to play a couple of videos of how CliniFace work, and if there's some time at the end, I will try to do a live demonstration as well. All right, so first of all, that's a 3D face which was loaded into the CliniFace or OBJ file. You can see by moving around, it's a true 3D file. And one of the first steps, of course, is to enter patient data, such as the birth of days, ethnicity, and the sex. And the main reason for that is the norm data depends on this information. And then CliniFace detected automatically the landmark position. And of course, the clinician has to verify the positions of those landmarks. So if you scroll with your mouse over one of the landmarks, CliniFace will tell you where the landmark should be. So that's one of our other patients where we use the face just in order to show where the landmark should be, and then we can the clinician can adapt the location of the landmark. All right, then the next step is that we actually, based on those landmarks, create our measurements. So we have here all of the different measurements which are possible. And if we click on one of the measurements, then another window pops up. So that's, for example, one of the measurements where you can see the norm curve for the specific ethnicity and gender, and then also the placement of the patient. So here you can see that the patient is within 1 standard deviation in the mean, and then the left distance, so distance of the left eye, so the patient's left eye is between 1 standard deviation and 2 standard deviations, and of the other distance is within pretty much within the mean. So we can then, or the clinician can automatically compare all of the measurements to the norm curve. Sometimes clinicians only use the function to actually access all of the norm curves because they normally come from lots of different references, and we try to make clear where we got our data from. So we always cite the reference of how we derived those norm curves. Then, of course, we want to find the one which are abnormal. So that means if you press on this button here, then only the measurements which are abnormal for the patients are shown. Okay, overall there are only 3 for this person, and then the clinician can click on them, find the information from the HPO, from the Human Phenotype Ontology webpage, and can verify what it actually is, what is abnormal, and then later on do the translation of how this term may be translated to rare disease. But that's to support the clinicians with what they already have done. However, we are able to add more. So for example, we can add interactive measurements, so measurements between angle, distances, and curvatures. So in this case, we create 2 landmarks, and between those 2 landmarks, which we can place random or over the existing landmarks, we can calculate the direct distance, we can calculate the surface distance, we can calculate the angle and the depth in X, Y, Z. So those measurements which clinicians so far could not use because it's quite difficult to derive those with a measuring tape using a patient. So what this tool also offers researchers to explore new measurements and correlate new, for example, curvature information as well, and curvatures are next slide, to see if we can introduce new HPO terms and to support the diagnosis of specific rare diseases. And we especially have close cooperation with the Westmead Hospital in Sydney, where we try to do this for FASD, the fatal alcohol syndrome disorder, which appears if mothers drink in their motherhood, when moms drink in early stages of the pregnancy. All right, so what's our program of work? Yes, we have the tool. We have been able to validate our data. However, we still have to, of course, keep developing the software. And one of the things we want to develop next is the placing of the landmarks for very small children or very abnormal faces. The small children, of course, the proportions are completely different compared to adults. And in order to overcome this, further work is required. Then using the tool, we want to create new normal data, especially for baby faces. Often these norm curves, as you can see here, they start in the age of 2 or 3 years. That's a reason that the face becomes more it's easier to sometimes just collect the data, but we want to try to find more information, normal information for very young children, because if you have very young children and you can diagnose a rare disease early on, it can be treated earlier. It can be treated earlier, it can have a very significant different outcome for the patient. Then we want to create normal data for Aboriginal faces. And that's very important because so far Aboriginal faces were compared to Afro-American faces. But of course, it's not really usable. And we have found already that some of the diagnoses can be very different because of the wrong reference data used. And then, of course, we want to use it also for clinical treatments and monitoring of the treatments over time. So we want to have a deformation, if you want, deformation analysis of one face over different time periods. And then similar to what we do with deformation, we want to try to quantify the deformation. So end users as FASD, I already mentioned that, and that's a protocol which is outputted out of CliniFace. That's a PDF document, and the reason for a PDF document is that it can file with the patient data. Okay, because if it's a 3D file, most of the systems used in hospitals are not able to store OBJ files. So I have to create a PDF, but in this PDF there's a 3D face embedded. And then for FASD, there are 3 criteria, and all of those information are listed here together, which then can be used for the diagnosis or for the clinician. All right, so coming back to the figures I presented early on, yes, we have identified the gap. Yes, we have found a solution, so 3D faces and photogrammetry, in order to derive the objective measures which the clinician wants. So that's a green tick. And if you're interested in the software, if you want to download it and play around yourself, please go to the webpage. It's free. It's also in GitHub available. Only thing you have to do is you have to provide with your email address, and they can download the software. Then, yes, we have a local knowledge base which we could use to trial to get the software to a stage where it's usable for clinicians. And it is already applied in the Westmead Hospital, but also at the Charles University in Prague for the analysis of rare diseases. So Westmead especially focus on FASD, and the Charles University in Prague has a special focus on autism. So we have already done the little bit better and bigger trials. So we are at the stage where we actually start to we are able to implement it in the clinical practice. And for this, we work closely together again with Westmead and Genetic Services in Western Australia, but also with Sing Health. So Sing Health is a major hospital chain in Singapore, and Takeda is a pharmaceutical company from Japan, who wants to use the CliniFace for intervention and monitoring, but for the already implementation in the general workflow. All right, so I hope I did not talk too much, and I have a bit of a break because I will play the ball back to you guys very briefly. There's another Slido survey. If I know that the majority of you have not worked together with clinical health, but maybe you can give me a bit of a feedback based on the first part of the presentation, what you believe is the biggest challenge when you work with in the area of allied health and medical research. So I just wait a little bit to see what you come up with. Yes, so with data quality, of course, I mean the data quality is if you take images of children that can move, so the data often doesn't have the best quality. Quantity is why you have to get the data, which actually not that easy to develop it. When I did my PhD, I worked in an interdisciplinary project as well. And for me, the biggest part was software development, because people always find some bugs, and everything's a focus on finding bugs and reporting them. Ethics, yes, we covered this already. But I think that's all still very much in the first place. No one actually picked the end user adoption, which is, if you want to do impact, it's one of the main things. All right. That takes me to my second project. And maybe I will close this the survey in a slide briefly. There's one more to come. And if you say, for example, software development, and next Slido survey, I would like to know what is it actually the thing where you think, what's your experience using a specific example of where's a challenge for you. Anyway, let's go ahead with the next slide and go ahead with the next project. Again, a little bit of a background of why this project is important to the clinicians and us as well. And this project is called SMART, which stands for Speech, Movement, and Acoustic Analysis Tracker. In Australia, around 1 in 5 children are not ready for school due to communication difficulties. The speech sound disorders is the most common communication disorder in preschool and school-age children. You can see on the figure here on the right-hand side, and that's for English. Of course, different languages have different the figure would look different. So what you see in different years, you develop the possibility to do different sounds. Clinicians still discuss with themselves which sound is formed, but overall, what you can say, well, if you're between 2 and 3, yes, you can say some words, you can't see many words. Then if you get older, the movement of the lips and the jaw becomes more refined, more fine, so you can actually then say all of the different louds. So the issue is that those speech disorders can have a significant impact to the children or to young adults, because it will create issues in the academic but also in the social life. So identifying speech disorders quite early on, especially in the age between 2 and 3, gives the best opportunity to overcome those challenges. So that's the reason why, that's the passion normally behind all of the speech pathologists. So what are the difficulties? What are the issues they have identified? Well, to do this kind of assessment, it's very, again, highly subjective. So to have more objective measures of what is normal and what is abnormal would help them to reduce the time required to do the assessment, but also to have a much more reliable assessment. And again, the lack of normative data, meaning for speech disorders, there's lots of information available for young adults and for adults, but not for children. So what's the overall aim here is we try to create an assessment tool which supports a fast, efficient, and more accurate objective diagnosis of speech disorders. All right, so I want to stress that. So how do we fit into the field? How can we actually, we as photogrammetrists or surveyors or computer scientists, how can we actually help speech pathologists? So overall, speech pathologists, they have a whole suite of tools which they use for their diagnosis. It's oral motor examination, it's hearing screening, it's just to review history, to listen to the sound, so more the acoustic information. But one of the things which is important is that they also start to use more video footage. So they try to use motor speech analysis using video footages. And that's where we come into play, because again, we have videos, we have images, we can try to help to provide more objective measurements based on the video footage. Overall, there are lots of different speech disorders, and only one of them is the motor speech disorder. So issues with the formation and deformation of the lips, the jaw, and so on. In the motor speech disorders, there are also 4 subgroups, subtypes. So there's a high level of complexity, just always to have this in the back of your mind. For the different subtypes, the clinician looks for different identifiers. So it's the speech movement, so the movement of the jaw, the lips, and other elements. Then also acoustics, to hear the different sounds important, and then also other perceptual marker, so deformation in the face as well. So what clinicians have done is they try to stage the different to try to stage it. So we have just a tone stage, then we have the mandibular control phase, which is a deformation across the vertical plane. We have labial facial control, and there's different controls, different stages. A speech disorder can happen if one of the stages is not all right. Okay, so is, for example, the mandibular control, if it's not developed, then there's a risk to develop a speech disorder. So what I have here on the left-hand side are the different stages. On the right-hand side, I have measurements which speech pathologists use in order to assess the different stages. The majority of the research at the moment is done related to stage 3 to 5. And that's the reason why I quickly want to explain those a little bit more in detail, because that's where we can help with video footage and photogrammetry. So the first one is the mandibular control. It means the movement in the vertical axis. So that's all located with the jaw range, the jaw opening. Then the labial facial control. It has something to do with the rounding of the lips and the rounding saying different words. So you can have you can open your mouth and you form an O, but you can also say O where you only use the lips and other muscles. And then the lingual control is that sound is made also in our throat. So the using the muscles of the tongues, but also the movement of the jaw in the anterior axis plane. Then mandibular control can be used for the assessment of jaw range, jaw controlment, and also the opening and closing. And the labiofacial control is represented by a stable jaw range and stable jaw control, but then the lip symmetry, the lip control, and rounding and retraction. And all of those things are things we can see in video footage, so things we can verify using objective measures. All right, let's have a look how it's done. So what clinicians have done for each of those stages, and for each of stage 3, 4, 5, and 7, they have developed words. So our 10 words in each stage. And those words, for example, bar or eye or map, bee, sheep, can be used to identify the different measurements, or different measurements are used using the different words in order to assess, for example, stage 3, the mandibular stage. So what the clinician does, if they want to assess the stage 3 mandibular, they have their 10 different words. For the 10 different words, they give ranking for appropriate jaw range and jaw control and so on. And based on those rankings, they give overall a score. And if a person consistently scores low in one category, then that's the indicator that there's a speech sound disorder. So they can try to train specific muscles with the child in order to overcome that. All right, so how does it work? And I apologize for this funny face, but due to ethics, I'm not able to show the complete face of this little girl. So what we have video footage. If we have video footage, we can try to, again, place our landmarks. And they're the same landmarks I presented from the CliniFace project beforehand, because those landmarks are clinical landmarks. They're not random landmarks created by different softwares. Well, if we have our different markers, again, what we can do, we can create measurements. For example, we can create the measurements describing the Pogonian vertical displacement. So displacement of the nasal point, which is shown here, with the point on the chin, right? So if we open the mouth, the distance increases, and then we can derive a measurement. We can have also a measurement for lateral displacement. That means if the person is sliding the jaw to the left or to the right-hand side. That's measurement, we call it Pogonial lateral displacement, so Pogonian in X direction. And then also how much the jaw is retracted. And that's then the Pogonian anterior displacement in that direction. And then we can have many, many more landmarks, measurements based on those landmarks. So the next step is then to connect those landmarks with the different measurements. For example, for the mandibular stage, the jaw range, in order to assess the jaw range, well, we need the Pogonian Y measurement. In order to discuss the jaw control, we need the Pogonian in X in that direction. And then based on those measurements, again, we can provide more objective measurements to the clinicians about the jaw range and jaw control. All right, just some graphs. And so what we can do, or if we track those measurements in the video of a patient over time, which is shown here, that's the period of saying the word B. The target word is B. And then we have here the Pogonian Y, so meaning the opening of the mouth when you say the word B. So in red is a profile, the kinematic profile of the patient. And the patient says B. So we can see while there's not much of a jaw movement, just a little bit, and we can then compare this to the mean data of children in the same age gap, which is a green line, the thick green line. The thin green line is a 95% confidence interval, and then the dashed blue line is the 1 standard deviation, and the thick blue line is the 2 standard deviation. So what now the clinician can do, it can compare the profile of the person, of the child, with the profile of other children. So those graphs are not perfect. For example, if you say to small children, say B, sometimes what's happened is nothing and then B. So there can be some offset issues. Sometimes there can be delay saying things and so on. But overall, you can see here that the red line is majority of the time within 1 standard deviation. So it looks like that this child has a very normal way to open the jaw when saying the word B. And you can see similar behavior also in the lateral displacement and anterior displacement. You can see that the red line of the child is pretty much within 1 standard deviation. So we can say it's pretty much normal behavior of saying the word for this age group. So if I look to the next slide, we can see that another patient, again, target word is B. We can see that the jaw arrangement of this child is pretty spot on. It's actually very good. So you can assume if you just look to the jaw range that the child doesn't have any disorder. However, if you look to the the lateral displacement as well anterior displacement, you can see something is going on. So while the child is able to open the mouth, so has the range, it has issues with sliding, but also with the retraction of the jaw. So there is a very strong indicator that there's some underlying speech disorder in the manipular stage, so stage number 3. So what we at the moment do is we provide those profiles to clinicians, and clinicians then tell us if those profiles actually help them to verify what they can see. Sometimes they just need the verification. So how does this tool work? And I'm sorry for this bar, but due to ethics, I'm not able to show the child. What you should be able to see is a child saying a specific word. All right, and I just have to turn off the sound. So it says the word bar, and the clinician as a first step has to find when the child starts to say the word bar, and then records the time when it starts and when it stops to say the word. So what you can see here, then we can say, well, that's the word bar. So far, clinicians looked at videos and tried to put this in Excel tables and so on. So have one tool which actually combines everything is already quite handy for them. And then the sound is turned off. Now we could, sorry, that's the next one. All right, now where we have the word bar, that's, come on, so sorry, I apologize for that. Now we have the word bar. We know when it starts and finishes. That means we can click on the word, for example, bar or eye or map. And what then the clinician can see automatically is for the target word, we create the norm histogram, and we map when the child is saying the word, the profile of the child compared to the norm curve. And then again, clinician can use this as a tool, as one of the tools in many tools, one of the tools in the big tool set to verify if there's a speech disorder or not. All right, so what we have to do, and SMART is not as far progressed as CliniFace, so we have to verify that the profiles we create is actually usable for speech pathologists. We at the moment run a validation with speeches, and they call them safe speeches, in order to verify if the tool is useful. And we still have to do is geometric validation. Being a surveyor, I want to make sure that the measurements we provide are accurate. So there are a couple of master and bachelor with honors students working on spatial intersections of landmarks and the accuracy assessment as well. And then, of course, other body of work like automatic detection of onset and offset, so to replace the clicking, and also to move away from just kinematic, but also more to acoustic analysis, so we actually can do a more differential diagnostic of children. All right, so what we have created a tool. We have a local user group, which is a telephone, speech and hearing group, which thinks, yes, it will help us. And we're at the moment in the stage to validate with them of how much is of help. And if it's of help, then the next step is how to implement it in the workflow. All right, and the next challenge, and that's another of the Slido surveys, is what do you think are the biggest challenges? And while you maybe type your challenges, I will already summarize my challenges. What I figured out doing both projects and a number of smaller health projects, that the communication is the main challenge. If you cannot communicate clearly of what you can do as a photogrammetrist with landmarks, and the clinician doesn't understand what can be done, what can't be done. But on the other side, if we don't understand what the clinician actually wants, if the communication breaks down, you will not go somewhere. And I just put up a couple of examples from the meetings in the last couple of months. So one of them is, if we talk as a surveyor, as the engineer talk about curvature, well, for us it's pretty clear. We have an ellipse, we fit the ellipse, we have the parameters A and B. Depending on the ratio of A and B, we have different kind of roundness. When clinicians talk about this, they talk about the muscles or the movement of the muscles. So you can create the ellipse by just open the mouth, create an ellipse, or you can create an ellipse by using muscles, like the O sound, right? So, and for them, just to the roundness by opening the mouth, it's not of interest. They're interested in the muscles and how the muscles interact. Also, when we talk about vertical planes, then vertical planes can be, sometimes they have different systems, and then you really have to make sure that you talk about the same plane. Motivation for long term, yes, that's a big challenge. The motivation is, if you work together with clinicians who are really passionate about their field, that's something which you can overcome. Funding is a very good issue, and the main challenge on funding is, and I have this on my list as well, if you do clinical research but you use science and engineering to put this in a grant for a clinical grant, it's often not understood, because we talk with science and engineering language, and the people who review the grants, their background is medical research. So it's very difficult to really explain what we can do and how it can help. On the other side, we are not allowed to apply for science and engineering grants because medical research is excluded. So we did rely on lots of small contracts with different stakeholders, and we really need a driver, a clinician for that. Then accuracy aspects, that's a good point. If you ask how much accuracy you want, well, they always want to have more than what is realistic and what is required. And we know this from lots of science and engineering projects as well. But coming to accuracy, it always also is connected to equipment. So we often have to buy specialized cameras in order to achieve the accuracy. They cost money, they need training. If they need training, it's not easy to implement it in the workflow. That's a challenge. So just to summarize, the communication is the most important for me. If this doesn't exist, it will not go ahead. However, if one of the other things do not exist, then it will not happen either. And working with children, there's a phrase in English, says never work with kids and animals. And the reason is it's actually difficult to work with them, because you cannot just say the word ball. It will not happen. So it's really to get data which are reliable for the analysis is the issue. Then, of course, the sample sizes are very challenging as well. If you work with rare disease, if you want to get 10 samples or images of a specific rare disease, that means to interview many, many people because, well, they are rare. Okay. And last but not least on my list here is also the end user adoption. The team is often not the issue. The team, they're all very passionate about what they want to do, but the communication is the main challenge. And I think I'm just finished on time, Lena, and I really want to show some faces. And there are the faces, the people who are involved in the project, and just to show you how many. So looking after ethics, for example, one specific rare disease, the end user engagement, captured data of Aboriginal faces, and many, many, many more people as well. So it's a very complex but fun thing, because as an engineer, I can see how I can make a real impact for people. And that's for my presentation. I really hope that you will have some questions for me.
Petra, thank you very much. It was great, very interesting. I always like presentation of projects which are closely connected to health and the human body and so on, which was your example as well. And I must appreciate that very much. And I guess that our participants as well, even though they haven't sent any question in the chat. So please, if you have a question, put it down to the chat. And maybe, yeah, I will give now my words to my colleague who is from the Students Consortium and who organized technically the event, and he will moderate now the part of the question and answers of the session. So Sune, please.
Thank you, Professor. We would request all the participants to kindly please put up their questions in the chat window.
I can see quite a few people online, so I'm very happy to see some of the names again. So Jens Reitloff dropped off, but I can see Thomas and Christian and many, many other people. So very nice to have you here as well. All right, I think I talked too much in this case.
So maybe I will have a question, and I will not put it down into a chat, but an oral one. Petra, was it applied also for detection of diseases, and how accurate or how reliable is to use the software?
Well, the software is one tool in a big suite of tools the clinician use. So clinicians always have used measurements. What we try to provide is more objective measurements.
Yeah.
So the clinicians which are listed, they use it actively. I'll just try to go out of that. I'll just quickly go up to the slides. So they're actually, so especially Genetic Services WA. So there are, this is within the Department of Health in WA, the partner who deal with rare diseases, and they use it on an everyday basis. They have a person who especially takes the images, and they use the tool also for their meetings. So when they come together, because the diseases are rare, so often they have once a week a meeting where they discuss different patients. And they use the tool doing those discussions as well, because they can look at the patient in 3D and they can do measurements. So to come back to your question, yes, especially Cliniface is already used by those experts, and they appreciate the direct access to the norm data. They appreciate that that's able to quickly visualize the measurements of the patient to the norm data and so on, but it is just one step in the assessment. And that's very important to emphasize as well. So to answer the question, yes, it's used. Yes, it makes the impact, but it's not the only thing. And our aim is not to replace the clinicians. That's often the overall, we use AI and we will find X, Y, Z. You actually can't replace the clinician. You only can support the clinician with the decision, because rare diseases, you don't have much data. You you can't apply, not yet, all of the AI and other toolbox which at the moment have available.
Yeah, I suppose that, but still it's a very useful tool, I guess, and there will be more and more experts who will use it in their practical work of clinics. And I guess this is just a continuation of what has been done in anthropology in previous centuries as well, when they have drawings or photographs and so on, but it was in a simpler way than you just provided.
Yes, and the good thing is, while the software is free because we want people to use it, and if you start to use it, that means you also overall get more 3D data. If you get more 3D data, you can create more normal data, and you actually can then start to refine the algorithm. So you will be able to identify new gaps. But it's very important for us, to make it available to researchers for free. So, for example, there's a Charles University in Prague use it quite actively, and the mask we use actually had the main contribution from the Charles University as well. So people are very excited who work in the field to contribute, which is excellent.
That's great. Thank you so much. The time is over, and I would like once again to thank you very much and wish you all the best in Australia and the others to avoid all the diseases, and for the experts not to have to use your tools. But this is just a dream for the future, and let's hope to see each of you and many others next year in Nice at the Congress. So good health to all of you.
Thank you.
Thank you, Petra. Thank you, Professor.
Thank you. Yeah.